Okay. All right, so starting over here, but welcome everyone. My name is Christy Gagnier, and I am from the Immersa team. And on behalf of our team and the Opioid Response Network, thank you for joining us today for this workshop of our Substance Use Across the Lifespan series. And today's workshop is going to be focusing on care transitions and support for older adults with substance use disorders and skilled nursing settings. And let's see. So first, Kimberly, could you advance the slide on to ORN, please? And so just really quick, this is sponsored by ORN, and for those of you who are unfamiliar with ORN, they are a nationwide network who provides support to various substance use prevention and treatment and recovery efforts across the country and provide low cost or no cost training and consultation throughout the country. And so they wanted us to highlight that they offer the TA training to anyone on request pretty much, and they have a request form at Opioids Response Network.org, which I'm going to just pop in the chat here really quick. Um, all right, popping that in the chat right there. So we encourage you to take a look at those. And why don't you go ahead and advance really quick, Kimberly? And so just a bit more information about ORN, although I think we can just skip through that really quickly, knowing that they are sponsored, they're a wonderful network. And then I'd like to jump in to introducing today's presenters. So first off, we have Kimberly Biting, who is an assistant professor at Vanderbilt University Medical Center, and her clinical work spans geriatric primary care and addiction medicine. We also have Dr. Megan Baresh, who is an associate professor of medicine and epidemiology at Johns Hopkins and the medical director of their Bayview Inpatient Addiction Consult Service. And her work focuses on expanding access to addiction treatment across care transitions. And we also have Consuelo Green, or Connie Green, who is a certified peer recovery specialist and registered peer supervisor at Johns Hopkins. And she has deep experience supporting people with substance use disorders in hospital and skilled nursing settings. So I want to say thank you, Connie, and Megan and Kimberly for being here. And I will go ahead and hand it over to you.
Great. Thanks so much for having us. We don't have any conflicts of interest. Dr. Biting receives some funding from HRSA and NIDA. And we have no disclosure. So really today the goal is to make it as interactive as it can be via a virtual platform. So thinking about stigma bias and barriers for patients with substance use disorders going to skilled nursing facilities or post-acute care or subacute rehab are all terms of the same thing. Talking about concrete strategies to help with actually making referrals successful for patients going from hospital to SNF, and then thinking about the educational needs of care teams, both on like the hospital and referral side and on the SNF side. And we're going to work through in the workout groups some toolkits to help address these knowledge gaps. So this is a high level. We'll go through kind of story background, kind of reviewing the problem, and then also toolkits that are already created that you can use in your settings, and then in breakout groups working through a practical case using one of the toolkits. And then we'll have time to report back and have a little bit for Q&A at the end. So first, we throughout we have some interactive polls. So if you can scan the QR code, you can also go into menti.com and put in that number, and then if you could answer once you pull up that polling, whether you work at a SNF, whether you refer patients to SNFs, no direct patient care, but involved in advocacy. We'll give it. And I'd also say as people are responding, keep this open because we're going to use this another time in the presentation. And if you keep it open, you can use it on laptop or phone, but whatever device you're using, then you don't have to rescan later. We'll just give it a minute. Give it a few more seconds, but enough time to at least get half of the group. I think we have over 60 people, which is awesome. Okay. So at least with we're still seeing coming in, but it seems like at least half of people are involved in advocacy rather than direct patient care in these areas. A quarter more on the referral side to SNFs and a quarter actually working at SNFs. So it's lovely to see the spectrum. I think especially as someone who works in the hospital, I'm so glad to see SNF colleagues here. All right. All right, I'm going to pass it on to Miss Connie Green to talk about stories and stigma from her experience.
Okay, hello everyone. I'm Consuelo Green, and I am a certified peer recovery specialist, and I'm a registered peer supervisor. And when Dr. Baresh asked me about participating, she was asking me about um, a patient that I might have had that had some success, and some patients that wasn't so successful. But I have one in mind. I met her here. I work for Johns Hopkins University, so I'll see the patient here at the hospital, and then they'll go to the SNF, and then I'll follow them to the SNF to see is everything going correctly. Have they been getting their medication? Um, is their care been taken care of, and just see how they doing. And from me doing this work for a lot of years, I worked with Dr. Baresh for some years, doing the pilot program with the same scenario. And it seems like to me, when the peer goes to the SNF, they are like super excited because a lot of times, people say, "Oh, I'll be back," and then you never see them again in life. But when I come back and I see them and they so excited. And then I'm asking, how's everything going? Is there anything that I can do for you? Sometimes they have appointments. I can help schedule appointments for them. I can help let them meet the social worker. I also meet the social worker and the case manager to figure out, what the discharge plan is going to look like because a lot of times the patient will see the doctor and tell Dr. B, yes, 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 I'm going to do it. Yes, I'm going to do it. And then when I come in and I say, hey, how are you? How's your day going? I'm not going to that sniff. And I said, well, give me one sec. I said, Dr. B, they ain't going. And she was like, thank you. It's like they will um, be more open with me because I've been through the process. And my clean date is May the 26th, and I'll have 12 years clean. And sometimes, most of the time, excuse me, my mouth's a little dry, but most of the time, um, they want to hear about your story. They want to know where you're at. How did it take you to get there? And I explained to them the entire process. I got a lot of therapy. I got a lot of groups, and just not NAAACDA, you name it, I was in there because I was trying to find my niche. And I also, have my own spiritual beliefs, and sometimes, patients, they don't want to go to meetings. They may want to go to the mosque. They might want to go to church, you have to find that thing, whatever that thing is, and stick with it. And consistency. I have to be consistent on a regular basis. I have to at least contact them once, maybe twice. Like you might have some patients where you really can see them AMA and as soon as you leave out the door And sometimes I have done it. I stood outside the door and said, "Let me see how long it take for them to leave." And then when they come out the door, I'll be like, "Ha ha." I'm like, "Where's you going at?" And they be like, "Oh, I was just going to get some water." And then they give me another opportunity to talk again and tell them, all the good things, that have happened in my life, in my family life, my children life. Um, it just seems like some of them think, well, let me give it a chance. And there's this one um, recently, and she's at the Helping Up mission, and she was one that you would have counted out. And right now, today, she have over 10 months clean, and she follows the directions there. She have her own therapist. She have her own what is it, counselor. Um, she get her medication um, delivered, and that's another thing. You have to make sure if they go into a skilled nursing facility that they have to have at least a 3-day bridge script because sometimes the clinic might not be open. They might come on a Friday, and I have done it. It's Friday evening. The people didn't come bring the methadone. I got my jacket on, my bag, and I'm giving all my shout outs. All right, y'all, see you later. And they said, "Kind, you got a patient on having methadone." I said, "Oh, Lord. They're going AMA. They're going to leave because who's going to stay, anywhere and they sick." So I built reports with all the not skilled nurse facility, all the programs, all the methadone programs that was in that area. So where I would come up there sometimes and get like 3 or 4 people methadone, which is a month long of methadone, 30 days, and okay, 30 days, and that's what, 369, that's 90 bottles of methadone. And that carries a lot of value in the community. So I built a rapport with the security. They walk me to my car, to make sure I'm safe, pull off, everything's good. I really, never had a problem with it, but um, sometimes you can have problems, like that. That's one of the barriers. If Yeah, wrap it up. Yeah, wrap it up. They say I got to wrap it up. Okay, so I'm gonna wrap it up, and how I'm gonna wrap it up, I'm just gonna say, um, everybody have a wonderful day, and the work is good. Um, you're gonna have some hiccups, but you're gonna have some wins as well, and it makes it all worth it for me. And with all that being said, I'm going to turn it over to Dr. B.
Thank you, Connie. It's a quick hour and she has a wealth of experience and could share for a long time. I will just we'll be quick with some of these background numbers. But I just wanted to brag on Connie and the role. It really has been, I've worked in different programs with transitions that having if you're lucky enough, this is Connie's role is grant funded to have peers who can help across that transitions. It's really been transformative. And instead of being a black box, when patients get to the skilled nursing facility, we actually can hear, are they getting, if they're on MOUD, are they getting their buprenorphine? And the patient she was referencing um, I had met in the hospital in the consult service. She had pretty serious like osteomyelitis, some wounds, had some physical therapy needs, but and was home. She was unhoused. So we know without Connie's and her team's support, she would have been discharged from the SNF to the street. But actually, Connie kept in contact with her, and that's how she was able to make it to a residential treatment facility where she still is. And that was, yeah, early last July that we met her together. And it wouldn't have worked without Connie and the team of peers. So I think that highlights it. That I think one example of how there's many stories of stigma that Connie could share that from SNF staff, from other things. So you can always reach out to her after. after this. So we just, I think, to acknowledge there can be success stories with supports, but that the barriers are real. That we know this is from some of, I won't get into all the numbers, but we know some of the work we've done out of the Hopkins health systems. There's been similar work out of Boston Medical Center in particular, showing that really focused on opiate use disorder, that there are SNFs are less likely to receive patients there's a longer length of stay in the hospital because case managers and social workers have to send referrals to more facilities, and it's usually lower quality care facilities. And then when we broke it down by type of MOUD, buprenorphine was helpful, but it was a particular barrier if people were on methadone. Next slide. And so I think this speaks to there are real logistical and regulatory barriers. We're kind of aware of that with methadone in general. Some specific things, looking at the specific issues related to the opiate agonist medications for opioid disorder, methadone and buprenorphine. So methadone, the SNF cannot initiate. Like all methadone for OUD, they can't prescribe. It has to be delivered, dispensed by an OTP and delivered. This is different than acute care hospitals and like acute level rehabs that can dispense the methadone on site. So like as Connie was mentioning, the delivery piece of the medication is a huge thing. There's still chain of custody needed. Although in our like dichotomous system, if it's for pain, the SNF could prescribe it. Buprenorphine, I think there's still stigma and it's like lack of awareness, but regulatory wise, it's just as easy as any other opioid to prescribe, especially since the elimination of the X waiver. So SNF providers can both initiate and continue medication. Any DA licensed prescriber can prescribe it. They can stock it from their own pharmacy just like they would. And they typically do stock other controlled meds, similar substances. And then usually I think one thing to know when working with them is especially if you're more from a hospital or addiction specialty group, is you probably need to work to figure out they're not going to have every formulation and every dose of buprenorphine. So it's good to figure out what is going to be most common and what's practical in there. Next slide. And then I just high level, these slides will be available, but to speak to there's real payer and cost considerations. This is a big opportunity for advocacy that leads to sometimes the barriers and lack of access to care. So consolidated billing and bundled services for the SNF side, especially from Medicare, means that the cost of the OTP and methadone is put on the SNF rather than the OTP. The OTPs, and we've been really lucky to have partners that are essentially doing pro bono work for the delivery of the interim methadone while the patient is at the SNF. But methadone for MOUD is not covered by Part D. The OTP can only bill for the weekly methadone delivery, and it's really difficult to get reimbursed. And so, from like medical director partner, they're told to bill, but they really don't get much money back. So just to highlight some policy changes that would be really helpful to increase access, unbundling methadone services provided by OTPs from the SNFs. So adding that to a list of excluded services so it actually can be billed for in the extra work. And then the other thing is if regulatory changes that would allow for SNFs to dispense methadone on site similar to acute care hospitals, that would be a big factor is the staff and cost of the delivery of the methadone. And who is going to do that? Is it everyone is busy? Is it the SNF staff? Is it an OT nursing partner? Most places are not lucky to have a Connie who's going to pick it up. So, yeah, next slide. All right, so we'll do this one a little quicker. So this is, we've talked about some things high level. What barriers have you experienced with patients who are recommended for or discharged to a SNF? I say patients with substance use disorders. And then I think it's free text. Okay, I'm gonna read this. Come on, stigma, SNFs not accepting them, nurses withholding medications like bupe, the issues of storage of medication, um, lack of, yep. I think if we were doing this in a word cloud, stigma would probably be the biggest word.
Yeah.
Um, and then ending up in the back in the same issue. Locations, obtaining meds, poor treatment. So I'll pass it on to Kimberly.
Thank you. Yeah, I did not mean to rush us. I accidentally clicked. But thank you. I'm gonna move on and we're gonna talk about some barriers to care for these patients, both sort of from the discharge from the hospital side to the facility, as well as in the facility themselves, some of which Megan has already alluded to. So there are a few barriers that it's important for hospital staff who are planning a patient discharge to SNF to be aware of, regarding both the limitations that the SNF may have from like an organizational, structural, or regulatory perspective, and then also some of the educational gaps that staff within the SNF may also have related to the care of patients with substance use disorder, which may make their care more complicated. So, as Megan said, um, there are SNFs that don't understand that methadone can't be prescribed or dispensed by the SNF. And so that's specifically related to methadone for opioid use disorder. Um, Other barriers to be aware of or SNF regulations to be aware of. So there are actually fewer rules or restrictions at the SNF compared to the hospital, including continued access to non-prescribed or street drugs. SNFs really can't. It's a rarity to restrict patients to go out on pass. It's a rarity to restrict visitors, right? There's been a lot of there's unfortunately a distant history of patients in SNF having a lot of abuse restrictions. And so, because of that, nursing homes actually are not allowed to do a lot of restrictions to patients. So, the patients are allowed to go out on pass, they're allowed to have visitors, and this may open up access, continued access to non prescribed substances. Other things to be aware of if you're trying to plan a patient going to a SNF is that transportation from the SNF to something like an OTP may not be feasible. One, because sometimes this transportation is not covered by insurance, and so it's out of pocket, which may not be realistic for a patient. And then many SNFs actually have rules where they want one of their staff members to go with a patient during a transportation, whether it's a transportation to a hospital for a clinic visit. But if it's transportation to an OTP for a pickup of a medication, if that transportation is too frequent, like if that OTP has not been part of an agreement to do like weekly or monthly pickups instead of daily pickups, staffing really is limited in the SNF, and they may just not have the staff to send with a patient to go to their OTP. Staffing barriers in terms of numbers is also is also a problem in SNFs. Usually there's like a 1 to 20 nurse to patient ratio for floor nurses, and those floor nurses are often LPNs, and then a 1 to 8 CNA to patient ratio. And some facilities actually only have one true RN per building. Those are federal regulations. And so patients that have higher medical needs or more like deep staffing needs, SNFs may say, we just don't have the staff to help take care of them. And then there is usually one social worker per floor per building for discharge planning, but SNFs don't have as many social workers as the hospital do in terms of care planning. Another thing that Megan alluded to is the SNF usually works with an outpatient pharmacy partner to do medication provision. So that pharmacy partner usually has a limited formulary compared to the hospital with fewer doses or formulations of something like buprenorphine. And these outpatient pharmacy partners cannot dispense methadone for OUD. And then facilities may be financially disincentivized to accept higher risk patients because they get their reimbursement based on the accepting diagnosis, and not necessarily some of the other complex diagnoses that the patient has, like a substance use disorder that requires sort of in-depth management, but is not sort of part of the reimbursement reason that they were accepted to the facility. And then within the facility itself, so those are barriers that I just talked about, are sort of anticipating when you're sending a patient to SNF what might come up. Within the SNF, too, there are some unique educational barriers that can complicate the care of patients with substance use disorder. A lot of it is related to knowledge of management of medications for substance use disorder in general, but particularly medications for opioid use disorder, lack of knowledge around induction, lack of knowledge around administration. So, for example, knowing that buprenorphine tabs are still sublingual, they should not be administered like a swallowed pill, right? Methadone wafers may need to be dissolved. These are things that staff and SNF may not be actually aware of, and they may be administering medications inappropriately. And this is sort of also an education point that I think helps combat stigma. But medications for opioid use disorder are evidence-based. They are harm reduction. They are not replacing one addiction with another. That's, I think a mentality that we're always trying to educate around, but it is a prevalent mentality in some SNFs as well. And then particularly for older or multi-morbid patients, really educating that medications for opioid use disorder are safe in older adults. They can be continued through end of life and hospice care. Those are education points that are often missed. And then there can be a lack of knowledge around naloxone, overdose response, lack of knowledge around withdrawal management or treatment. And then again, getting back to those methadone regulations, where methadone for opioid use disorder is regulated very differently than methadone for pain or end of life care, which SNFs manage all the time. So that can be a little bit tricky, and those are education needs always. So this is actually from a paper that I was involved in, where we conducted 24 semi-structured interviews with nursing home staff across 11 facilities regarding barriers to care for patients with substance use disorders. And what we found is really there's like three main barriers. There are training gaps, which I alluded to, stigma, and limited resources. And specifically, the limited resources often result practically with really variable admission policies that each SNF sort of makes up themselves and may vary widely. And so there's really a need for standardized protocols and workforce education across the SNFs nationally. So these are two example quotes from one of the interviews in our paper that shows how admission protocols can be specific but variable. Each facility designed their own protocols, which led to specific and sometimes impossibly high admission requirements. So this first quote, this SNF evaluates a patient's access to substances, their mobility, what is their risk of visitors? Can they maneuver their wheelchair? Like, how functional are they in sort of like trying to anticipate some sort of activity that the SNF does not want. The second quote is relates to the fact that the SNF has put in a policy that patients on MOUD have to self-administer their MOUD. The nurse cannot administer that to them, which, by the way, is not the case for any other medication that a patient in a SNF would need to self-administer their own meds, right? So this facility said, we FaceTimed the resident in the hospital and said, can you tell me how you self-administer your medicine? Do you know your dose? Can you hold a pen? I need to see your dexterity. And they were even checking to make sure the patient could like open the package themselves. Again, not a requirement for any other medication except for this one. So just another snippet into what SUD care can look like in a SNF. This is also from our paper, and our paper actually looked at facilities that had both formal OUD programming versus informal OUD programming, and staff at both groups of facilities agreed that they should accept patients with a history of substance use disorders, but staff with formal programming were significantly more likely to feel more confident in responding to things like overdoses, which highlights, I think, that protocols and proper planning for caring for certain groups of patients really empowers staff as well. And I want to end this section with a point of positivity. This was a follow-up qualitative study where we interviewed residents in skilled nursing facilities with a history of substance use disorder on their experiences in the SNF. And so what we really found, patients said that the SNF really can be a positive side of recovery for them, because when you have your medical and your social and your physical needs taken care of, you can focus on things like recovery. And then barriers to recovery in SNFs are really variable and depend on the facility itself, which makes sense. Um, and lived experiences with substance use disorder care and harm reduction with these residents were really heterogeneous, which also makes sense. Everybody has a unique story. And because of that, their needs, the needs of patients with substance use disorder and SNFs encompass multiple domains, and really care needs to be individualized to the patient. So one of the patients in this study said, well, I'm not around alcohol. I'm not using. It's a nice place to be, if you try to get, straightened out and you want this. And then another patient said, yeah, the therapy was really helpful because it helped me get through a lot of stuff I was dealing with. So I want to end on this positive note that SNF residents with substance use disorder, they find a lot of stability. And so it's our job to just make sure we can care for them best while they're there. So to that end, we're going to go quickly through three toolkits and two advocacy tools that you can use to help care for your patients going to SNF. This toolkit is hot off the presses from EMERSA. It's designed to help us manage a very real gap, which is safely transferring older adults with substance use disorders into skilled nursing facilities. And the key idea in this toolkit is that substance use disorder care in this population needs a geriatrics framework. So it uses the age-friendly health systems 5Ms framework, which is encompassed with what matters most: medications, mentation, mobility, and multi-complexity. Those are our 5Ms. And it guides the user to think beyond medications for opioid use disorder alone, to anticipate other issues that may come up, like delirium, cognitive impairment, fall risk, mobility limitations, polypharmacy, and social complexity. And I will say you'll have links to all of these in the chat that you can use in your breakout sessions. The second major function of this toolkit is operational, because it provides structured discharge workflows, SNF communication tools, checklists and templates, and guidance for managing medications for opioid use disorder for the SNF, who may not have as much expertise on that. And this is critical because SNFs are a common point of treatment disruption, especially for patients on MOUD. And so this toolkit helps us ask the question, how do we ensure continuity of evidence-based substance use disorder care across settings? And this is another example of a workflow. This is a different toolkit, which is a larger, it's like over 100 pages. It's from the Massachusetts Department of Public Health. And it helps skilled nursing facilities care for residents with both opioid and stimulant use disorders. So it has a little bit more breadth in terms of the type of SUD. It has some education around understanding opioid and stimulant use disorder, creating a stigma-free environment with workforce competencies and transitions of care. It does also include like some wonderful appendices with process maps, templates, and policies. It emphasizes communication between OTPs and outpatient providers with templates and consents and forms that you can use. And it standardizes how SNFs maintain continuity of care. This also adds in some evidence-based behavioral interventions and structured environments for stimulant use disorder, as well as staff training to recognize intoxication, withdrawal, and cravings for stimulant use disorder, and harm reduction and overdose awareness in the setting of especially polysubstance use. Tip 26, if you guys haven't heard of it, it's like my Bible. It's a key guideline for treating substance use disorders in older adults. It's especially relevant when we're sending patients to skilled nursing facilities. The main point is that substance use disorders in older adults looks different, and it's easy to miss. And so it's such an important reference guide, But it's got tips like this where it says, how can administrators create a treatment environment responsive to older adults? Um, it talks about medication management in the aging patient. And it sort of encompasses the complexity we should be thinking about. So tip 26 is great. And now let's talk about a few advocacy resources, and then we're going to go into our breakout groups. So this is a one pager that details signs of discrimination on behalf of a SNF and how SNFs can provide access to medications for opioid use disorder and resources to help people experience discrimination. This is from the Legal Action Center, specifically around OUD and healthcare and skilled nursing facilities. This is a beautiful editorial by Sean Cohen et al. On ending medical complicity with skilled nursing facility discrimination against people with opioid use disorder. And it really highlights ongoing discrimination against patients with OUD, particularly around refusal to admit patients receiving medications for opioid use disorder, which, by the way, is illegal under the Americans for Disabilities Act, but it still persists. And so this article goes through 6 points. They say you should know the law and name discrimination when you see it, advocate for your patients during the referral process, educate SNF staff and leadership, ensure continuity of medications for opioid use disorder, partner with interdisciplinary teams, and escalate when necessary. So I sped through those, but we're going to go over those in depth in our breakout groups. You'll get these instructions once you're in your breakout groups as well. But for 5 minutes, you guys can discuss in your group experiences with SNFs. And then 10 minutes, take a toolkit. You can choose your own, or we'll assign one to you if you don't know which one to choose. And I want you to identify one barrier or educational opportunity in a case that you've either experienced or we've given you a case above. And then use your toolkit or resource to say, what should happen in this case? What would you say to the SNF? What's a workaround or educational opportunity? And use your toolkit. So if you didn't get a chance to scan any of the toolkits, we've got QR codes here, and then Christy's going to put them in the chat as well. So I'm going to stop my share as we go out into breakout groups.
All right, so I'm going to send everybody out into a breakout room, and you'll see there's a suggested toolkit for you there. But if it doesn't work for your group, you're welcome to try another one. And do you want, Kimberly, do you still want this to be 15 minutes, you think?
I think we should probably make it 10 because
10,
we're going
okay.
to do some group sharing. Yeah.
Okay, all right, I will cut that down to 10. Okay, all right, so I'm going to send everybody out, and we'll see you shortly.
Can everybody see my screen as you're trickling back in?
Yeah.
Great. Okay, great. So I think people are trickling back in from the breakout rooms. Hopefully they are. Maybe Christy, you could just check and make sure we haven't lost some folks, because it looks like there may be still some people trickling back in. I wanted to just open it up. We've got we only have a few minutes, so I'm going to put this report back down to 3 minutes, either in the chat or you can unmute. I would love to hear somebody say what toolkit they explored and what barriers they identified based on their group discussion with a practical solution for this barrier using a toolkit. I see somebody has raised their hand. Marlon?
Hi, we were actually group 5, and in group 5 we discussed one of the articles, the last one. SNF patient discrimination and some of the solutions that we were kind of talking in the time given. One of the things that came up, as you mentioned initially, is that the discrimination is often one of the major drivers against accepting individuals as OUD in skilled nursing facilities. And as we discussed, a opioid use disorder is considered a disability, and by rejecting someone, they're opening themselves up for a lawsuit. You cannot discriminate based on a protected class and a protected characteristic of an individual, in this case, a disability. So reframing it for skilled nursing facilities and having them understand, hey, we want to work with you. We understand the limitations. However, I want you to understand what you stand to lose. If you do not understand that this is a requirement, the patient may just come back and sue you. Not that we're trying to advocate for that, but this is the contextual reality of the situation. And I will end it there.
Thank you so much. Yeah, I think that's a very important reminder. I know some states have actually done a really good job of like creating legal precedents around this. Massachusetts has a bunch of court cases that you can use as legal precedents, but you're absolutely right. So that was group 5. Who else, what other group would like to come up and just briefly share?
Well, I can't remember which group I was in. Oh, tip 26, whatever group that was. But I mainly talked with the nurse practitioner that was there, and we were talking about barriers to getting methadone treatment for patients. But another issue also came up was like um, accepting certain patients based on a number of factors. And I know it sounds really simple to say, oh, that's a discrimination, but in a way, there's lots of things to consider, not just whether that person has a disability or not. Almost everybody in there is disabled in some way. So you look at, are these instances where you can manage the person while they're there and then provide a good discharge once they leave? And a lot of times, we look at admission, discharge on admission, and what's that going to look like? The other thing that factors in, how long has it been since the person has been on uh, opioids, and are they just getting on methadone? Are they just getting on buprenorphine? There's a lot of factors to consider, providing safety for that resident and the other residents that's going to be housed with that person. So, I mean, it's not just a black and white issue. There's a lot of gray area and a lot of obstacles to overcome when you're trying to take somebody in that position.
Great, thank you. Yeah, I think that's such an important perspective, and I hope you'll explore tip 26 more because it's really such a useful and very in-depth tool. Um, we have in the chat, I'm going to just read it out. Group 7 explored the Legal Action Center and discussed the barrier of nobody wanting to pick up methadone. And they came up with some solutions of getting the OTP to dispense longer amounts and education that anyone from the SNF can pick it up. It doesn't have to be a nurse or provider. And there could be a peer from the OTP or the SNF, and maybe it may be able to bill for outpatient services. Very good. Anybody look at the Massachusetts or MRSA toolkits, and then we're going to move on. Anybody look at the Massachusetts or MRSA toolkits? I think we had two groups for each of those.
I was in group 1 and we didn't discuss it explicitly, but I'm looking at the MRSA toolkit now and I really like the flow diagrams. This is like, I'm going to share this with our hospital staff who are frequently communicating with SNFs and trying to teach around the process. I think it could be a really useful tool.
Yes, so I would encourage all of you to please look at the flow diagrams. They are really actionable and there are samples that you can use and SNFs that SNFs can use on the SNF side too. Okay, great. So we're going to do the commitment to change at the same time as we're going to open up to the Q&A just for time. But if you could share in the chat one specific action item you're going to implement in the next 4 weeks. It could be related to education, systems, or advocacy. And it may be related to using something in the toolkit that you've explored today. So just pop in the chat one thing that you're thinking about doing going forward related to one of these topics. And as you're percolating on that, we're going to open the floor for some questions. If you guys have questions, you can put them in the chat or you can shout them out. And we're also we would love an evaluation. And here is the link as well. So put in the chat either a question or your commitment to change in the next four weeks. Great. I'm seeing some things in the chat. Thank you, Chanel. I love the education focus. We've got somebody else in the chat saying they're going to meet with the hospital transition staff around advocacy when communicating with SNFs. Oh my gosh, love that. So start thinking about your commitment to change, but we're also here for any questions that you guys might have. Okay, so I have wonderful commitments to change coming in and also a question. Jennifer says the nursing homes I work at put in restrictions to out of pass with patients with use or with PICC lines. Did you say that nursing homes are not allowed to do this? No, they're allowed to restrict pass, but I would be cautious about why they're restricting pass if there's like a discriminatory reason. It should probably be like the exception instead of the rule to restrict pass. So you theoretically facilities can restrict pass, but being preemptive or punitive is probably not appropriate and like opens you up to various discrimination concerns, I would say, if it's not for if it's just a blanket policy, it can be a little bit nebulous. Megan, do you have thoughts on that
I was
too?
going to add as a education resource because we deal like there's growing evidence, especially from infectious disease literature, about people who go home with lines for home OPAT with substance use disorder, how it's safe, how they're not tampering. So you can also use that as a resource as you're trying to educate people. If concern over line tampering is the reason that they're doing those restrictions because there's no let freer space when people are home and in the community. So just add that. Any other questions? I think we're waiting in the last couple minutes, and I think I don't know, Christy, for those who have questions, we can hang out for a few minutes longer. We know it was a quick hour. The slides are fully available. The recording's going to be available. The links to all the amazing toolkits. I will just also, it's in the references, I believe. And it would just also highlight with success stories that the paper by Tassiano on OUD meets was a pilot we had that did show and does have some flow diagrams. Did involve some grant funding for the peer role, who was Connie at the time, but strategies within the existing regulatory framework to make sure that methadone and buprenorphine are continued. So just to highlight that as well. That it is possible, like while we talked about advocacy changes, that it is possible in the current framework. Just a lot of education needed. And then if your hospital does dispensing at discharge, which we do, would make that's that's been really helpful with SNFs for us to dispense the 3 days that the patient can go with. They go with transport, not a nurse. It's like the patient and transport. And that at least helps with giving more buffer for the OTP to deliver or the SNF to pick up from the OTP.
They mentioned it once already too, but I'm just if you were hoping to get CE or CME credits for this, I'm popping those links in the chat one more time. Also, the survey link for our GIPR survey, which helps us get information to SAMHSA to keep these types of funding going. So if you could fill out that survey, we'd be very grateful. And you will receive emails with all of these as well, as to reiterate. But unless Kimberly, Connie, Megan, unless you have anything else you'd like to wrap up with, I think we can probably go ahead and conclude. Thank you everyone for coming. Thank you, Connie, Megan, Kimberly for leading this workshop today. And we will hope to see you at the next Immersa workshop or advocacy webinar coming up in the future. All right. Thank you so much, everyone.